Perfect. Okay, thank you for the introduction and thank you for the invitation to talk this morning. What I'm gonna talk about is some of the work that have been done in the last couple of years in my lab at UCSF. And let's get going. So if you imagine a radiologist performing his clinical duty, this is how it looks like. It's a human looking at an image, trying to make somehow a qualitative assessment on what they see. And if they feel very brave, try to diagnose the disease. And if they feel even more brave, to try to predict the trajectory of the patients. This is a very imperfect way of doing it. Humans, even if they are incredibly experts, it's very difficult for them to try to get a trajectory right. The usage of AI with medical imaging in the radiology setting can really help us making this process more quantitative and making it more quantitative, reliable, and be able to actually do a trajectory of the patient. In the next 15 minutes or so, I'm going to tell you the journey of my lab in the last 10 years to try to get to not be really just looking at images, to try to do some quantitative trajectory of the patient. And let me take this down. And ever in medical imaging and MRI, my expertise is particularly in musculoskeletal and aging of the musculoskeletal system. We look at MRI. There are 3D volumes, and often we want to quantify anatomy and pathology within the joint. So we want to get biomarkers as volume, shape, and to do that, we need to do semantic segmentation of the different tissue. This was an unmet challenge for the longest time, but 10 years ago, 2015, the first UNet model was presented, and all the variants of that give us the opportunity to extract high resolution surface. This is a high resolution surface of the knee joint, femur bone on the top and tibia bone on the bottom. This type of model kept the lights on in my lab for 5 years. This is a very general purpose solution. It can be applied to all different anatomy, intervertebral disc, knee, shoulder, muscle, those are most musculoskeletal applications, some collaboration outside of the lab in liver transport, transplant, brain tumor, all the possible applications are really possible with this architecture. The only problem is that they need to be retrained all the time, which is okay for research setting, but it's not okay for clinical settings. This is not acceptable in clinics. In fact, this model was perfect for research, never really translated into clinic. Doctor today, 10 years later, do not use that at the hospital when you go and do an MRI, but still look at your joint exactly as in the first slides, which is a very old school way of doing it. Everything changed last year when Meta released the segment anything model. This is a foundation model. It's a composable model which is promptable. It can be prompted with text or with visuals, which means with text I can say segment for me the tibia bone in an example of an MRI, or with points or bounding box around the tibia, so very fast human in the loop annotation. This is a foundation model. It's trained a little bit brute force, so it's not a self-supervised paradigm that we usually use in foundation model, but it's actually fully supervised, trained on 11 million images and 1 billion masks, which is completely order of magnitude higher than what is usually done. The couple of years of now embarrassing using of UNet give the lab a gigantic data set of annotated images, which allow us to do a very in-depth analysis of the performance of MSK-SAM when used zero shot, because the only way of going to the clinic is this model need to be used out of the box with no annotation from the clinician. It will not be feasible with the clinical practice. And this is a very busy slide, but that was a very involved analysis. In the image here, the image on the left, some comparison of SEM, the first release, the SEM2, which is considered to be used for video, was thought to be used for video, but it works very well on 3D structure using the slice of the 3D structure as frame. And the MedSem, which as you see in this image, and you also see here in some quantification, is the pink box work much worse than the other two original release from Meta, which is surprising because MedSam is a version of SAM that is fine-tuned for medical imaging. So what happened there? And this is not the first attempt of fine-tune a foundation model to a specific domain and have actually failure, and the original foundation model being better than the fine-tuned one. And what happened here? It happened that medical imaging, from a computer vision perspective, from an imaging perspective, is not a semantic group. So ultrasound and a CT and an MRI and a MRI of the brain and an MRI of the knee has nothing to do from a computer vision perspective. The only thing that they have in common is in our head, they come from the same domain, but in reality, they are just all acquired in the same building. That's the only thing that they have in common. So from a computer vision perspective, from a machine learning perspective, they are not a semantic group. So makes the attempt of fine-tune a specialized model not really a good choice. And this happens all the time. I know we're going to talk about fine-tuning and context learning. So I think that is a good point. Now that we have this solution, we are able to extract. We have the possibility to extract a surface like that that represent the bone shape of your femur on all the possible MRI that is extracted, fully automatic, no human intervention, real time. So how we analyze that, how we can extract a biomarker that can help us with the diagnosis. One biomarker for osteoarthritis is the shape of your joint. Osteoarthritis itself modify the shape of the bone. So we need to do a shape analysis. And let's look at how can we do it. So from a data structure perspective, this is a cloud point. So we can leverage everything that is done in computer graphics for point cloud analysis. This is very computationally expensive, so we will not go that route. We can use a graph neural network. This is a mesh, so it's actually the data structure is actually a graph, but the length and the strength of the edge are an artifact of the resolution of the image, are an artifact of the sampling of the mesh. So graph neural network will not be the way to go. But we can use a trick. So in this particular situation, the shape has a spherical topology, which means I can go in the center of the shape and look into a line and meet the surface just in one point. So it can be unwrapped in spherical coordinates. And basically, the image that you see there is the projection of the shape to a sphere that encloses it. And the is a compression version of the surface and get all the information that you need. And now it is an image, so you can use your best bet for image analysis. It can be a convolutional model, it can be a visual transformer, anything will work there, and process this image and ask questions. Can I use this image to diagnose osteoarthritis? And it comes out that we can do it very well. So the AUC is the ability of this model to predict, to actually diagnose osteoarthritis, and is very high, and is much higher than what a radiologist will do by looking at the image itself. The more interesting question and more challenging question: can I predict the future? Can I predict how this, if this person will develop osteoarthritis in 5 years from now? Those are images from control subjects that do not have osteoarthritis, that get a screening scan, and we say, okay, can I predict who is going to develop osteoarthritis in 4 years? And those are some results at 2 years and 4 years. This is encouraging. That means that these images bring the signal, to do this task. The random chance will be that line, that dashed line, the black dash line. So we definitely go much higher than random chances, but it's still too low to be actionable. With a probability like that, you will not change the lifestyle or will not give a drug to the patient. So we need something more. And the problem here is really machine learning based. This problem is very unbalanced. Thankfully, if you screen a lot of people, a lot of them will not develop osteoarthritis in 4 years. So it's a very unbalanced problem, which makes the classification model struggle, and the ability of collecting enough data set to train large model it's difficult. But we have the ability with generative AI. We just said in a couple of slides ago that if I have your image today, I'm very well in diagnosing. What if instead of having your image today, I try to synthesize your image in 4 years, and then I can use that same model to actually predict, to actually diagnose if the synthetic image comes from an osteoarthritis patient or not. This is exactly what we did. This was 2022, so a couple of years ago in terms of generative AI, and we use 3 different scan from ears. Let me go to the next slide. I know this is busy, but I'll go over. So in the right side is the whole graph of the model. We do the whole analysis exactly as described before. We obtain the surface. We do the spherical coding. We take that for 3 consecutive years, and then we use image generator, which was simply unit based. The only interesting aspect is that we use a composed loss in the generator. One is L1 that look at the low frequency and the large differences, and can have a mode collapsing, so can give you something that is too smooth. And to fight that problem, which is typical in image generation when you use just encoder decoders, we use a structural similarity to actually have a part of the loss that look at the high frequencies and the texture, so the small details. Those are competitive losses, so it's pretty hard to train, and often they need to be trained asynchronously during training, and maybe you start with an L1 and then you turn on the structural similarity at the end when the model already have a sense of this what is reconstructing. We wanted to have an attention mechanism that makes the model focus attention on what it counts actually for the diagnosis. So what we did is somehow a prequel of what we call today knowledge distillation, which is my favorite training regime of ever. So what we did is to pass the embedding, pass the features to the model that diagnoses osteoarthritis, and make sure to align the embeddings of the real image and the synthetic image in the embedding space of the diagnostic model, and the final loss is the combination of that. This is some example in the first of one example of results. In the first row is let me do a time check. In the first row is a real image. The color is because it's a difference map between your 4-year scan and your baseline scan. So where you see the bright color is because there are a lot of shape changes. So, and I was very happy to see that in the inside of the knee is called intercondylar notch. So in the intercondylar notch, we see a change that is typical in osteoarthritis, which is the rotation of the condyle, and the little dot, this is what is called an osteophytes, which is incredibly painful. And so in this case, it wouldn't be perfectly predicted in exactly the position where it's going to happen 4 years in advance. That could trigger physical therapy, lifestyle changes, drugs when available, to actually avoid this patient to have this pain. So this brings me to the end, and I think we are one step closer to my two first two slides, which were pretty much a vision on what we can do, marrying AI with the radiology. And this is true in the clinical setting. We can do patient similarity and risk profiling, longitudinal health monitor, and personalized treatment and decision, all things that are holy grail in medicine today. And on the research aspect, so maybe we can develop a drug for these people, which does not exist. We can do causal discovery and hypothesis generation. This synthetic data generation can actually help to develop digital twin and synthetic arm on clinical trial, and do clinical model and development and testing. This is all I have today. These people are a wonderful member of the Center of Intelligent Imaging and Musculoskeletal Group at UCSF, and some of our funny conference pictures here.